Hi, welcome back. This is Tracy, and we're going to continue on with aseptic technique and talk about a little bit more of surgical asepsis. So just take a look at this picture for reference. It's really good for the pictorial learners, and we will kind of progress on through the intraoperative period of perioperative medicine. So when you think about surgical asepsis, the above picture shows that the left side is the traditional surgical scrub. You can see that the person will start by cleansing their fingernails, and they typically have a little plastic nail cleaner along with the sponge inside of the kit. There are typically a couple of different types of soaps that can be used, as well as a betadine scrub, but the person will wet their arms, clean the fingernails, and then begin the surgical scrub. The surgical scrub typically should take probably about 3 to 6 minutes. People that are scrubbing into surgery have to keep their fingernails short, and artificial nails cannot be worn simply because they do harbor too many microorganisms and are a really great breeding source for bacteria. The scrub will be about 3 to 5 minutes, and then once the scrub is completed, it'll be followed by a rinse. And rather than, how we normally rinse our hands off and then kind of shake the excess water off of our fingertips, with surgery scrubbing, you have to keep your hands above the elbows, so you'll keep them positioned so that water runs off of the elbows or arms rather than the fingertips, because we're trying to maintain the fingers as being the cleanest part. Once that scrub is complete, the person will enter the surgical suite, and then that's where they will begin to don the sterile gloves, gown, those types of things. So it's important, very, very important, you need to know this, that when you are getting ready to scrub, that eye protection and the hat, mask, shoe covers, all of those things are going to have to be put on prior to starting the surgical scrub. Once the person enters the surgical suite, then that is when someone will hand them a towel to dry with, or they will have a sterile towel opened for them, and then once they are dried, it's considered that the forearms to their hands are clean and ready for donning the sterile gown and gloves. You may see people utilizing an alcohol-based surgical gel, but typically that is only to be used once a surgical scrub has been completed, and then subsequent times they can use that surgical cleanse. With surgical scrubbing, there is a broad spectrum surgical antimicrobial solution that is used. Talked about the length of the surgical scrub, and it's really important to use vigorous friction so that you get any of the microscopic organisms and those types of things from under the fingernails off of the skin, because we all know that skin is a huge breeding ground. With these pictures, you'll see them shown on page 271 of your Iggy book. You'll see that the nurse is scrubbing in this first picture. You see they have lots of nice soap and bubbles, and then you're getting ready to rinse in the second picture. You can see that the hands are held well above the elbows, and then these final three pictures show that they're getting ready to put the sterile gloves on. They have the sterile gown on, sitting on top of sterile equipment. So these are kind of good pictures to look at. Please note the water falling off of the hands and arms, and the foot handles that you can see in picture B. That's how they control the water turning on, turning off, and the flow of it. With anesthesia, the thing you need to consider when we're talking about anesthesia, anesthesia does induce a partial or total loss of sensation with or without loss of consciousness. So we talk about things patients having conscious sedation. That would be utilized with patients that have, say, colonoscopies, EGDs, and then with the general anesthetic, that's going to be the most invasive, where a person is put completely to sleep. Hopefully, the result of the anesthesia, the patient will have some analgesia, so they will have pain relief or pain suppression, and then with that amnesia, they will have memory loss and won't remember what happened to them during the procedures. We also see nerve blocks being utilized if patients need carpal tunnel surgery, if they're having elbow or shoulder surgery. We might see those nerve blocks being utilized. The basis idea is to ensure our patients have loss of feeling and then also have amnesia from the procedures that are being done. With general anesthesia, we will see our patient having reversible loss of consciousness. What's going to happen is that our patients will be given something either inhaled or via the IV to induce central nervous system depression. It results in the anesthesia, analgesia, amnesia. Our patient will lose total loss of consciousness, and so the patient that is undergoing general anesthetic will require mechanical ventilation, so intubation, and so this patient is going to need to be monitored closely. So we'll want to make sure that they are hooked up to cardiac monitoring. We'll want to watch their temperature. Oftentimes they'll just put a little tape across the patient's forehead and can monitor temperature. The four stages of general anesthesia are then listed next, and let's really hope that we don't ever get our patient to stage 4 or the danger phase of analgesia anesthesia. With stage 1, that is basically the administration of the analgesic or sedation medication. The patient will go into a period of relaxation. So many of you may have seen on television where they ask the patient to count down backwards from 10 to 1, and then typically by the time they get to 1, they're going to be asleep. So that's a time where our patient begins to have nice relaxation and continues to tolerate the analgesia. Stage 2 is the excitement or delirium stage. Typically it begins with loss of consciousness, and then will end with a deeper relaxation than what stage 1 can provide. You might notice these patients having irregular breathing, maybe a little bit of increased muscle tone, maybe some involuntary movements. When you see those, they probably would resemble the patient, or if you've ever seen anyone in a REM sleep, the rapid eye movement, that's kind of maybe what the patient will look like. The patient is still susceptible to external stimuli, so I want to make sure that we're staying close to the patient. We are keeping the patient safe and comfortable, and then also being emotionally supportive if need be. And then stage 3 is going to be the operative stage. That is when the generalized muscle relaxation begins and ends with loss of reflexes. So if you were to do deep tendon reflexes on a patient who is in the operative or analgesic phase of anesthesia, you would not be able to elicit the reflex response. So your patient has no response to pain. So during this time, it's really important, especially for prolonged procedures, to ensure that we are watching bony prominences, making sure that our patients don't have skin breakdown, those kinds of things. In stage 4, that's a danger sign, as you can see listed up on your slide. During this time, the patient's vital functions are depressed, and it can end with either cardiac arrest or respiratory failure. And then obviously, if we have such complications, our patient could end up dying. To determine how our patient is tolerating, we want to look for pupils. Hopefully they don't become fixed and dilated, because that is a sign that there has been injury to the death. The emergent phase then is when our patient recovers from the anesthesia, and the emergent phase is going to be very dependent on which type of anesthetic agent is used, how long the patient has been under the anesthetic, and then whether they had to use a reversal agent or not. So there's different responses for different patients dependent upon what is going on with them. The administration of general anesthetic can be administered via inhalation, IV injection. This is on table 17.1 of your IGGI book, page 272. With the inhalation, we just put the mask and it is the most controlled. We put a mask over our patient's face and let them begin to breathe in the anesthetic. You must use, or your nurse anesthetist, anesthesiologist has to use other agents for painful or prolonged procedures. So the inhalation will provide relaxation and amnesia, but doesn't do well for pain control. So we do need to be cognizant of that. With the IV injection, there is a very rapid onset, a very nice induction to surgery. Sometimes the patients will complain of burning at that IV site, and then they may need to slow the push of the medications down a bit, or oftentimes the patients will be asleep before they're even done with that. So those are going to be a couple of ways. Balanced anesthetic, there's usually minimal disturbance to the psychologic function. There's not many side effects, and it can be used very well with older or high-risk patients. So it's going to be really important to know the medications the patients are taking, know their histories, and then just be aware that pharmacologic effects on the body may be unpredictable. Some of the adjuncts to general anesthetic agents, the hypnotics, opioid analgesics, and maybe the neuromuscular blocking agents. With your hypnotics, you would maybe be using like Valium, Versed, Ativan, Xanax, some of those types of things. Opioid analgesics are going to be your mu agonists, so morphine, fentanyl. Those are going to be a couple of things with that. The neuromuscular blocking agents are going to be utilized to paralyze the patient so that your nurse anesthetist or anesthesiologist will have an easier time intubating your patient as well. As I just briefly stated, the balanced anesthetics are very good for specific populations to obtain specific effects. So it talks about using nitrous oxide for amnesia, morphine for analgesia, and the pancuronium for muscle relaxation. So you will see these medications being utilized, especially when you do your surgical follow-through during advanced concepts. Complications from general anesthesia, they can range from minor to annoying, so maybe like the sore throat that the patient gets after being intubated, or as severe as the malignant hyperthermia, which is listed out as the top complication on your slide. It is acute, life-threatening complication from certain drugs being utilized for general anesthesia. What happens is the reaction begins in skeletal muscles exposed to this specific agent and causes increased calcium levels in muscle cells, which causes increased muscle metabolism. So with that high rate of metabolism, that's what increases our patient's temperature. And what will happen is the clinical features reflect increased muscle calcium level. So our patient will have manifestations such as tachycardia, dysrhythmias, muscle rigidity, and then myoglobinuria, which is the presence of muscle proteins in the urine. Basically, the temperature can be as high as 111.2 degrees Fahrenheit. If it gets that high, that's going to be a late sign of hyperthermia. Survival is going to be dependent on early diagnosis. So as in nursing with everything, Early intervention, early treatment, better outcomes. Overdose of anesthetic can occur if the patient's metabolism and drug elimination are slower. So, our patients that maybe have liver failure, that would be a problem for them. We want to look at the patient's height, weight, and medical history, taking a look at renal and liver functions as well. Unrecognized hypoventilation is failure to exchange gases adequately, which can lead to cardiac arrest. And then intubation complications can include injury to teeth, swollen lips, vocal cord trauma. Sometimes with our larger patients, intubation is difficult, so we do need to help our nurse anesthetists when we are able to.